Hello everyone. In this class, we'll try to learn how to perform clinical examination of motor system. The apparatus required are percussion hammer, that is knee hammer, and a measuring tape. The motor system is assessed under the following headings. The nutrition has to be assessed. The muscle tone of the different group of muscles is to be assessed. Then the strength of the muscles, that is power. Then you have to look for the coordination of the movement, gait, and involuntary movements if at all they are present, and then the reflexes. Assessment of nutrition of the muscles or the bulk of the muscles. Using measuring tape, measure the circumference of the muscles at fixed point on two sides and compare. The upper limb nutrition or the bulk has to be measured at 5 inch above and 4 inch below the elbow joint, and in the lower limb 9 inch above and 6 inch below the knee joint. The muscle atrophy is seen in cases of myopathy, motor neuron diseases, and poliomyelitis. Then the tone of the muscles has to be examined. Tone of the muscle is nothing but it's a state of partial contraction in skeletal muscles at rest. It is assessed by degree of resistance offered to passive movement against the action of the muscle. The flexion and extension movements are carried out passively by the examiner at the shoulder, at elbow, wrist, hip, knee, and ankle. Normally, there is a slight degree of resistance will be offered when the muscles are stretched. The tone of the muscles can also be assessed by the feel of muscle when it is fully relaxed state. Normally, the feel of the muscle will be dovi, and it may be increased, or in case of hypertonia, and it may be decreased in hypotonia. So this is how, we are going to passively going to stretch the muscle. Okay, so when passively the biceps muscles are, when the hands are extended, then that leads to the passive stretching of the biceps, and the tone of the bicep will be assessed. In a similar way, so when the arm is flexed, it is going to stretch the triceps muscle, and the tricep muscle muscle tone will be assessed. Okay, so that's how the muscle tone can be assessed in the most of the joints. Like it can be assessed in the shoulder joint, it can be assessed in the wrist joint, in the upper limb, and similarly in the lower limb, the tone can be assessed in the hip joint, knee joint, and at the ankle joint, and also at the interphalangeal joints. Okay. So this is how, the tone of the muscle is going to be assessed in the upper limb at the elbow joint, and this is how you're going to assess the tone in the wrist joint. Hypertonia is increase in the muscle tone, and it is of two forms. That is, it can be a spasticity or it can be a rigidity. Spasticity is where the tone is more in one group of muscles, that is in agonist muscles, than in other, that is in antagonist muscles. And rigidities, there is increase in overall tone of the muscle in both extensor and flexor group of muscles. Normally, the clasp knife rigidity, it is a spastic type of rigidity. It is seen in upper motor neuron lesion, and lead pipe rigidity and cogwheel type rigidity, where the muscle tone is increased in both flexor and extensor group of muscles. It is seen in Parkinsonism. Spasticity, there is a great resistance at the beginning of the passive flexion, and it gives away suddenly on continued pressure. Okay, and the muscle feel firm. It is an important sign of upper motor neuron lesion. It is marked in the flexors of the upper limbs and extensors of the lower limb, that is in anti-gravity muscles. Then you have to assess the power of the muscles. The power is assessed by asking subject to actively move the limb without and against resistance applied by the examiner. The subject's power is compared to the examiner's power. Other factors like age, sex, build of the subject has to be considered. Normally the power is graded and there are 6 grades of power, that is 0 to 5. The grade 0 is total paralysis when the person is asked to move the limb voluntarily. So there will be total paralysis, there will be no movement at all. And the grade 1 is there will be presence of slight muscle flickering. Grade 2 is normal range of movement without the effect of gravity. That is, gravity is eliminated by proper positioning of the limb. And moving limb should be the parallel to the ground. Then grade 3 is normal movement against the gravity, but not against the examiner's resistance. Grade 4 is normal range of movement against gravity and with moderate resistance, whereas grade 5 is the movement possible against the gravity with a full resistance. So the power has to be assessed in all the group of the muscle fibers. Okay, so in the upper limb as well as in the lower limb. The power in the group of muscles is tested by asking the subject to perform voluntary movements as follows on the both the sides, as I told. Okay, first you have to test the power has to be tested without the resistance but against the gravity. So that means he is having at least grade 3 power, and if not possible, then with the elimination of the gravity, here the grade will be obviously 2 or less than 2, and if it is possible, the resistance should be applied. So then it should be more than 3 or 4 or 5. As I told, the power should be tested at the shoulder joint, where you'll be testing the flexion, extension, abduction and adduction. At an elbow joint, the flexion and extension should be tested. At wrist, flexion and extension. In the lower limb, at the hip level, flexion, extension, abduction and adductions are tested. At the knee joint, flexion and extension, and at the ankle, plantar flexion and dorsiflexion are tested. Okay, so this is how the examiner is testing the muscle power of the interphalangeal joints, that is flexor group of the wrist joint. So the plegia means the paralysis of the muscle fibers. There can be different when there is a loss in the power. Okay, it could be because of the paralysis of the muscle fibers. The paralysis can be the hemiplegia or paraplegia. It can be quadriplegia or monoplegia, or it can be a simple the paresis. Okay, hemiplegia, the body affected are of the side of the body, one side of the body, and usually the site of lesion will be internal capsule. Paraplegia is involvement of both the legs, and the site of lesion will be the spinal cord below the mid-thoracic region. And in quadriplegia, all the 4 limbs are affected, where the lesion will be in the spinal cord in the cervical region. Monoplegia, only one limb is affected. It may be the involvement of the nerve plexus, and the paresis is nothing but the decrease in the power in the muscle. Okay, so which can the site of the lesion could be in nerve muscular junction and muscles itself, and some of the causes for muscle paresis are myasthenia gravis, myopathy, and muscular dystrophies. Then coordination of the movement are to be assessed. The coordination of the movements is regulated by cerebellum, extrapyramidal, and vestibular system. The loss of this integrity and control leads to an incoordination of the movements. The coordination is tested both in upper and lower limbs, and all the tests have to be carried out with eyes open first and then later eyes closed. This is to differentiate between the sensory ataxia and motor ataxia. In upper limbs, the finger nose test. The subject is asked to stretch out his or her arm and then to touch the tip of his or her nose with the tip of his index finger. The procedure is repeated with the opposite hand. Normally, the subject is able to perform these accurately, uh, both slowly and rapidly. In cerebellar disease, on the side of the lesion, the finger moves towards the nose in wavering fashion. There is a tendency to overshoot the object instead uh, of the normal smooth movement. And in posterior column lesions, there will be oscillations of the finger in various directions near the nose, made prominent by the closure of the eyes. So this is how the person is able to do normally uh, finger nose test. But in case of cerebellar disease, when he approaches near the examiner's fingertip, there will be wavering movements. Making a circle, ask the subject to make circle in air with his or her finger and let him repeat the on other forefinger. Then rapid alternating movements. The subject is asked to clap one hand and alternatively with the dorsum of the other hand quickly and repeatedly. The inability to perform rapid alternating movement is called as dysdacokinesis. This is the feature of cerebellar lesion. In lower limbs, you must perform heel-knee test or knee-heel test. The subject has to be in supine position. Ask him to place one heel on the opposite knee and then to slide along the shin to the ankle and back again. The procedure is done also on the opposite side. The heel overshoots the knee with oscillation from side to side while it is moved down the leg in cerebellar disease. The heel is lifted high and falls off many times during its downward course in case of sensory ataxia. So this is how you differentiate between the motor and sensory ataxia. Okay. So here the person moves his heel from knee to the ankle. Then walking on a straight line. The subject is asked to walk on a straight line and turn to walk back. Normally, he is capable of doing this. In cerebellar lesion, the subject deviates to one on the other side and takes a zigzag course like a trunk. Then Romberg sign. It is not a test for cerebellar function. It is a test for loss of position sense, that is sensory ataxia. The subject is asked to stand with his or her feet close together, and if it is possible, he is asked to close both the eyes. Normally, there is no loss of balance. The subject sways or falls in sensory ataxia, that is lesions of the dorsal column of the spinal cord, or that of dorsal root, example in case of tapes dorsalis, because of the loss of sensory information from the legs. Okay. In sensory ataxia, the person will be uh, able to, if with able to stand with the open eyes. But in cerebral ataxia, even with open eyes, the person is unsteady on his or her feet. And that's how you can differentiate between sensory and motor ataxia with the Romberg sign. Gait. It is a posture of the subject while walking. The legs of the subject should be adequately exposed and feet should be bare. He is asked to walk away from the observer in a straight line, to turn around and at a given point and come back. So these are some of the gait disorders: a spastic gait, waddling gait, high stepping gait, ataxic gait, and fascinating gait. Spastic gait can be hemiplegic gait, where it is only one leg is affected. It is also called as circumduction gait. In paraplegia or quadriplegia, both the legs are affected. The walking is typically crisscross pattern, and this type of spastic gait is called as scissor gait, which is very common in cerebral palsy in children. Waddling gait, where short steps with a clumsy swaying motion, it occurs in muscular weakness, that is especially proximal muscular weakness, which is seen in muscular dystrophies or osteomalacia. High stepping gait is usually seen in polyneuropathy, uh, and ataxic gait is seen in case of cerebellar or sensory ataxic gaits. And fascinating gait is also called as shuffling gait, and it is a typical feature of Parkinsonism. Then you have to look for any involuntary movements they present. These can occur either at rest or during voluntary movements. They may be localized or widespread, that is, they may be generalized. The localized involuntary movements are fibrillations, fasciculations, myoclonus, and tremors. Tremors are nothing but they are to and fro oscillatory movements of the part of the body from alternate contraction of opposing agonist and antagonist group of muscles. They may be fine or coarse, rhythmic, and occur at rapid or slow rate. They are divided into static or resting and intentional or action tremors. Static tremors appears like pill rolling movements of the hands. They are slow and coarse and diminished on voluntary movements. They are seen in Parkinsonism. The tremors of the head and lips are also seen in elderly. They are called as senile tremors. Intentional or action tremors. They are fine tumors at fast rate. They are noted when the patient stretches the arm in front and keep the hands extended. They are noticed in thyrotoxicosis, chronic alcoholism, excessive smoking, and anxiety states. In cerebellar disease, the tremors are detected when the patient is asked to perform the finger nose test. That is, tremor appears when the finger approaches the nose. Some of the generalized movements are chorea, athetosis, tonic and clonic spasm, or tics. The chorea is it is an involuntary, irregular, non-repetitive, purposeless movements of group of muscles which may occur in a disorderly fashion in the limbs, or it can occur in the face or sometimes all over the body. It begins abruptly and uh, ends suddenly as a jerky movement without being sustained. It is aggravated by excitement and on voluntary movement, and it is going to disappear during the sleep. It is seen in the lesions of caudate nucleus, as it happens in case of Huntington's chorea. Okay, so it can be a feature of rheumatic fever where the caudate nucleus is involved. Athetosis, they are slow and writhing stereotyped movements of the limbs due to the extrapyramidal lesions. They increase on voluntary effort and disappear during sleep. And this is how the report has to be uh, written, where you'll be mentioning about the nutritional states of the arm, of the upper and lower limbs, you have to mention about the tone uh, in both the upper and lower limbs. Then you have to see for the right of the power of the group of muscles, whether they belong to which group. That is normally uh, the grade 5. They'll be having grade 5. Then you have to look for the coordination in both upper limbs as well as lower limbs. So then you have to mention about the what type of gait, whether it is normal or abnormal, and then you have to mention about the involuntary movements, if at all any. So this clinical examination is going to help in differentiating the upper motor neuron from the lower motor neuron lesion. Okay. So the type of paralysis in upper motor neuron will be usually spastic, and in lower motor neuron lesion it will be flaccid. Okay, so you see atrophy in upper motor neuron lesion. I mean, there can be disuse atrophy, but in lower motor neuron it will be very severe. The deep tendon reflexes are exaggerated in upper motor neuron lesion, absent in lower motor neuron lesion. There can be positive Babinski sign in upper motor neuron lesion. The plantar reflex is absent in lower motor neuron. Superficial reflexes are absent in uh, upper motor neuron lesion as well as in lower motor neuron lesion. Fasciculation could be present in lower motor neuron lesion. They'll be absent in upper motor neuron lesion. So this is how you have to perform uh, the examination of the motor system. Thank you.